Hi, I'm Luis Ortega from Barcelona. I'm interventional cardiologist. Today I have the pleasure to host Dr. Gilbert Tang from New York, from Mount Sinai Hospital. Dr. Tang is a cardiac surgeon, and he recently presented in the TCT Connect virtual meeting the study called EXPLANT, in which they analyze explanted TAVR prosthesis from patients. So I will ask you, Dr. Tang, in terms of the background, the methodology, and the results, which are the essential results from your study?
Well, thank you very much for the invitation to talk about the EXPLANT TAVR registry, which is a truly global collaboration among 38 centers all over the world on this important project. What we're looking at is that because TAVR is now approved in patients who are any surgical risk, and also we know the limited durability of prosthetic valve, that just like redo TAVR or valve-in-valve TAVR, redo TAVR and also some of the patients who cannot have redo TAVR who need surgery will likely happen. But we don't know much about what happens to these patients or why do the valve fails, because there are limited data out there. There have been a couple of papers recently published, including my colleague Yoshi Kaneko from the JACC, looking at the CMS in the US study, but these are based on claims data, but no real pathology data or echo or data on these detailed outcomes. So essentially what we did is we have about over 200 patients, 223 patients, spanning from January 2010 all the way up to this August, looking at patients who had the valve explanted. So because of that, we looked at multiple things on these registries. So we found that the mean age of these patients was 70+ years old. They actually, some of them were considered low risk, about 28% of them. The reason for them having surgery is multifactorial. So the sites claim that unfavorable anatomy for redo TAVR is around 19%, and the median time to explant the surgical valve was around 13 months. It was about half and half between balloon expander versus self-expanding valve, but 41% of them were due to endocarditis, which is not surprising because there's really no transcatheter solution for patients with infected prosthetic valve. About 23.6% of them were structural valve degeneration, about 15.9% were paravalvular leak. Now, of course, this spans a long period, so it does span across multiple valve generations. So, we haven't had any analysis on the most recent generation valve yet. However, interestingly, urgent emerging cases account for almost 50% of these cases. Thankfully, we found that most of them just require redo surgical valve replacement rather than aortic root replacement. Aortic root replacement remained quite low, around 14%. However, almost 50% of the patients did require combined cardiac surgery procedures. The procedure mortality was very low, was less than 1%. The in-hospital mortality around 10.8%. However, if you look at the one-year outcome, it was mortality is around 28.6%, with 10% stroke. So even though this is a very selected group done by high-volume expert TAVR and surgical centers, this project essentially is more hypothesis generating, and we want to look into more subgroup analysis as well to see what if there are any predictors for adverse outcomes for explantation and for more difficult surgery. I think what we need to look at overall, both patients, both with transcatheter valve failure undergoing surgery, but also redo TAVR, to look at the entire cohort to see what anatomy or what factors would favor one treatment option versus the other. We have seen papers published exclusively on redo TAVR as well, but however, we know that this is a highly representative selected subgroup because only the patient with anatomy that are favorable will be able to undergo redo TAVR. So this registry is also ongoing. You can reach out to me via my email at gilbert.tang@mountsinai.org, or you can find me on Twitter at gilberttangmd if you want to participate in this registry. Thank you.
Many thanks. Very, very, very interesting. I have to say, in my center, the experience with explanted TAVRs is low. Is an infrequent situation. We have 2 cases that I can recall right now. It was one in which the valve prolapsed to the aorta. We try to keep it free from the aorta, and we make aorta dissections. And the other one was an annulus ruptures and rupture from the aortic ring. I have to say that both of them were acute, so we saw the complication in the table. And the prognostic of the patients, in that moment, I believe it was, the patient will not come out from this one, but they do it. They were discharged from the hospital. And then something that I like from your study, that you commented, that you have the follow-up after the discharge, because probably something we interventional cardiologists are missing from the cases we have in our hospital. We do the procedures, and most of us do not do a follow-up from these cases. So it's very interesting, very interesting.
Yes.
In terms, it probably is not an interventional cardiology question, but I am a very curious person. So can you elaborate very short about the procedure for explant? Because our surgeons tells us that it's a nightmare of surgery to explant a TAVR, depending on the time from the implantation to the explant. Can you give us some insight about that?
Yeah, so this is important to note that our EXPLANT TAVR registry does not include acute explant, meaning that the patients who had explant during the same initial hospitalization from the TAVR is excluded, because we don't want to have those confound with our other patients. What we are more interested in is the patients who had the valve for at least a period of time and then require explantation. And that's why we had a long period of patients requiring explant, which is on average more than 6 months. As you are right that the longer the valve has been in place, there could be some endothelialization for certain valve, very tall frame. It could have some healing with the native aorta. So it is a little bit more delicate to explant these transcatheter valves. And also we need to make sure it doesn't damage the coronary, doesn't damage the annulus as we extract them. There are some tips and tricks that has been presented and published by one of the co-authors and colleagues here, Dr. Fukuyama from University of Michigan. So he's had quite a lot of experience with this, and he's presented some of his work. But I agree, it's definitely not isolated surgical aortic valve replacement. It's definitely a little bit more challenging, but thankfully, very, very few of those require aortic replacement.
Okay. And one last question. As you as cardiac surgeon, regarding this study and this finding, you have to give interventional cardiologists only one advice. What will be that advice?
Well, I think my advice is that TAVR is like wonderful therapy in appropriately selected patients and require heart team discussion. And also, interventional cardiologists need to be mindful that just because you have a TAVR now doesn't guarantee you that you can do another TAVR in the future. So we have to be very careful advising our younger patients where we know that TAVR has a certain durability, and that their surgery after initial TAVR may still be a possibility. We just don't know all the answers yet, and we still need to learn more.
I fully agree with you. We are still learning. And I believe that I'm interventional cardiology. We have to learn from surgeons because you have a lot of more experience doing both than us. So I think that putting the patient in the center and making the best decision in the heart team is the way to go. So Dr. Tang, many thanks for your time from this wondering presentation that you have given us. And this interview was done for the virtual meeting Structural Heart for King Fahad Ahmad Hospital in Jeddah. I hope you enjoy this presentation as I have done. So many thanks, Dr. Tang, and goodbye.
Thank you very much.